Hello, everyone. Welcome to Arash's World. Today we have a special guest, Dr. Mark Burish. How are you doing?
I'm good. Thanks for having me.
Wonderful. So I do the first question is usually the toughest, but maybe easier in your case. How would you briefly describe yourself to our audience here?
So I'm a neurologist and a headache specialist. I spend half my time seeing patients, mainly with headache disorders, and I spend half my time doing research, mainly on cluster headache. I'm in
Mhm.
Houston, Texas at UT Houston.
Mhm. And so you work mainly with cluster headaches and also part of the Will Erwin Headache Research Foundation. Is that correct?
Yes, so I'm at the Willer and Headache Research Center. We get our funding from the Willer and Headache Research Foundation, which was named for an individual, Will Irwin, who committed suicide because of his cluster headaches.
Mhm.
And I see patients with all different types of headaches, but my research focus is cluster.
Mhm. So let's start off with cluster headaches. First of all, what are they? What may be a cause there? And then later on, I'd like to also see what can we do about it.
Yeah, so cluster headache is a fairly rare headache. It's about 1 in 1,000 people. It's a little bit different than what you might think of as a dehydration headache or a migraine. So these headaches are extremely severe pain. Patients say it's more painful than childbirth, kidney stones, gunshot wounds, you have it. It lasts very precisely between 15 minutes and 3 hours. You might have them up to 8 times a day. And then during the headache, you're either very restless, so you're pacing, you're rocking, you can't sit still, or you have all these changes on the same side as the pain. So the eye waters, the nose runs, something like that. And the name cluster, where it got its name, is that the headaches will come every day for weeks at a time. Then they might go away for a year or 6 months or something like that, as if the headaches are kind of clustering together.
Hmm. And do we know is it genetic? Do we know any causes or what is the research so far? What's it showing us?
Yeah, it's genetic. It runs in families maybe 6 or 7% of the time. So usually we don't think there's like a single gene that probably explains it. Um, we don't really know exactly what causes it. It usually starts in your 20s or 30s. A lot of patients were smokers before they ever got cluster headache, but obviously most people who smoked never get cluster headache, so we don't really know why.
But predominantly smokers, so that could be an extra additional risk, you would say, perhaps?
Yeah, so it's more common in smokers. It's more common in men. Unlike a lot of other headaches, like migraines, more common in women. This one's about 2 to 1, 3 to 1 men. Um, so yeah.
Do we know or do we have an idea what could trigger it, what could cause it? I mean, with I used to have migraines, and there were certain things. If I didn't eat, I didn't have enough sleep, I was stressed. Those were factors that played a role. Is it similar when it comes to cluster headaches?
Yes, it's kind of fascinating for cluster headache. Outside of the cycle, if you're not having headaches every day, it's been a while, there's nothing that we know of that triggers one. Inside of a cycle, the major triggers are alcohol, but unlike migraine, it's within an hour. I'll have patients say, before I finish my beer, I've already got a cluster headache. For migraine, it's often hours later or a day later.
That's right.
Nitroglycerin, which is a medicine we use for heart disease. If you're having a heart attack, you get nitroglycerin. That will very reliably trigger a cluster headache. Other than that, not a lot of other ones. The typical things you think of with migraine, if you don't sleep enough or if you're really stressed or menstrual cycle, those don't seem to be triggers for cluster headache. And outside of a cycle, if you're not having headaches for a while, you could drink all you want, take all the nitroglycerin you want. I don't recommend that, but you could without getting any trigger and causing any headache.
Mhm. So that would be the treatment. It would medication, and that usually works.
So yeah, so we have some pretty good treatments. They're not perfect, and so we're still working on better ones. But it's basically medications to prevent it. We don't. There's no surgery. There's no cure that we know of. We have medicines to break a headache while you're having it, and we have medicines to kind of prevent or decrease how many headaches you get.
Mhm. And one of the things we also look at here on my podcast is also things like influences like stress, anxiety, and so on. And is there a type of correlation there? Could it be like also like enhanced because of feeling stress or anxiety? Could that make it worse? And I do believe in my view, in my experience, they were closely linked. Once I was able to deal with my stress, and it was chronic stress, the migraines went away, and I used to have it on a weekly basis. And now that everything has changed, I rarely have it. And so it's quite fascinating that what we can do when it comes to our mental health and how that can again influence our body in different ways. Would that be a potential factor there as well with cluster headaches?
Yeah, we don't know. So in migraine, there's been a lot of recent research, kind of like you're talking about, into mindfulness things,
Yes.
um, different things, and they've done clinical trials now, and it really does seem to make a difference in migraine.
Mhm.
For cluster headache, we haven't seen that as much, although patients haven't tried it as much, as far as the either meditation or biofeedback or kind of all these lifestyle things. No, it may be the other direction in the sense of cluster headaches have this very odd thing where they happen the exact same time every day, like clockwork. And
Oh,
they can be 2 in the morning is the most common time. So you can imagine patients aren't sleeping very well. And so the headaches, just as painful as they are, lack of sleep, those can cause stress. It's just the kind of the question of the other direction. Can the stress then make the headaches worse or not? Some patients have said they think stress makes it worse. Other people have not noticed a correlation.
and so, what about other things like nutrition? When we look at nutrition, or something I've been doing was intermittent fasting too. And although it seemed at the beginning to cause headaches, because again, I was not used to it, after a while, it did plateau and got much better too. Are you maybe trying out some of these additional methods to help with the treatment? Are you yourself maybe trying out different things to see what would work for the patient?
Yeah, so we haven't tried intermittent fasting, but I think that's a fascinating idea. And the reason I think so is that we do think that cluster headache has this very circadian pattern to it. They
Mhm,
happen the same
mhm,
time of day. If you look into it a little bit more, there's changes in your melatonin levels. That's kind of your hormone, nighttime hormone. And there are things you can do to kind of disrupt your own circadian rhythm. If we give patients melatonin, that sometimes actually helps their cluster headaches. It's not the strongest thing we have, but it helps. Steroids are kind of a daytime hormone. So the daytime hormone is steroids, the nighttime hormone is melatonin. If you give a daytime hormone, steroids, that actually works very well for cluster headache patients. And so maybe the way those are working is by altering your circadian rhythm. Intermittent fasting is another way to kind of disrupt your circadian rhythm a little bit. So it might be a different way than you were talking about, or maybe it was the same for migraine, but it may not be the nutrition part of things. It may actually be the circadian part. I'm not aware of anyone that's actually tried intermittent fasting for cluster headache. And I'm not, you might have to do it differently when you're out of cycle versus when you're in cycle, but I think that'd be a fascinating idea.
And so when you say it's the same time, is so it depends. Each individual, it's for them, it's a different time. So I
That's
find that very interesting, actually.
Yeah, so and this is a big part of our research is the circadian part, but patients, if you look at all patients, it's 2 a.m. And that's whether they've done big studies in the US, they've been big studies in Europe. It doesn't matter what time zone you're in. 2 a.m. is
Oh
the
my
most
goodness!
common time.
Wow. Okay.
And patients are it's pretty accurate within maybe an hour or so. So it's I had one patient once that I was asking about all the headaches, and the guy said, look, it's my headaches usually happen around 3:15. If you want to wait, you can see what they look like. That's how confident he was it was going to happen. But you're right, for patient number one it might be 2 a.m. every day. For patient number two it might be noon every day. But I've also had patients say that it changes with each cycle. So in 2020, when they had their 3-week cycle or 4-week cycle, it happened every day at 2 a.m. A year later, when they got their next cycle, it was every day at 4 o'clock in the afternoon. So it changes based on person to person and maybe even within a person year to year.
What I find also fascinating is that there seems to be a pause in between, right? A time where you wouldn't have any headaches, and then it comes back. So I'm just like I don't know how would that work? I mean, with in my case with migraines, I my stress was constant, so was my headache then, and so
Right.
I but like there was a reason for it that I can see. So is it just random, or again, we just need to know? We just need to know more research about this.
Yeah, it's very interesting. So for migraine, I think of it sometimes when I talk to my patients, I try to describe it as you have a threshold for migraines. And sometimes the stress is just enough to kind of trigger that migraine. And other times it's not. Maybe it's stress plus not eating or, some combination, and then that threshold kind of triggers your migraine. For cluster headache, that threat that gets turned on and off. There is something that gets turned on and you have headaches every day for a while, and then something that turns off, and no matter what you do, no matter how much alcohol, we just don't know what, there's nothing you can do to turn it back on. It's going to turn on when it's going to turn on. So one of the big, I think, fascinating things with cluster headache and what we're trying to research is what turns it on and off. Because if we
Yes.
could figure that out, we could, theoretically shut down the headaches.
Is there also maybe in correlation to that, maybe seeing a mental health expert to find out psychological factors too that could be an interplay with it? Is that something you look at too, or do you just see it as just a physical medical issue here?
No, for any chronic pain condition, psychological factors are going to be a big factor. And so usually it's depression, anxiety issues. Cluster headache has been called suicide headache. There's a very high rate of suicidal thoughts and things during these headaches. So we do try to make sure that we address that side of things. If things that the thoughts start getting really dark, that to talk to somebody, it's a little bit of a different conversation than your typical depression, because again, these a lot of these patients will be anxious or depressed when they're having headaches, and then when the headaches are gone, those things kind of go away, and they don't have that kind of thing that's making them sad or depressed. So it's a different conversation, I think, that the therapist or the psychologist, psychiatrist has to have with them to be aware of in the moment versus outside the moment, but you've got to be kind of thinking about both.
Yeah, I think, and on this podcast, where I'm really promoting is a holistic view of things, and so trying everything and maybe not knowing what works, but as long as it takes away the pain or you can relieve it, I think that's really important. But you're talking about the onset is usually in the 20s, so is it possible to get it at a later age, or is it very uncommon to see that?
I think the youngest it was ever seen was 2 years old, and the oldest was somewhere in their 90s. So it's
Oh,
possible kind of
oh,
throughout the lifespan. Most people I think you see is somewhere between 15 and 55, somewhere in that kind of teens to 50s type of thing. So it can happen later. We don't really know, again, what turns it on in the first place, but there's nothing that we know of that prevents it. I would love to tell everyone, if you just eat right, or
okay.
if you have a good kind of mindfulness to life, things will be okay, but we don't know what turns it on or off. I agree with you on the wellness side of things, for migraine especially. I know we're not mainly talking about migraine, but there we have a lot of treatments, including these mindfulness things, including um, a variety of different things they've been doing in clinical trials. And so those things, there's no medication. The side effects are a lot less. We sometimes used to call them lifestyle changes, where you make sure you get enough sleep, you drink enough water. Those things are cheap and easy. They're hard to do sometimes because you really got to stick to a schedule. But if you can, it's a great, easy, non-pharmacologic, safe way of trying to prevent your headaches.
I think it's always to include that, right? Whatever the issue is, just include that. Again,
Right.
as you're saying, because it doesn't have side effects. Takes some effort in some cases. I think exercise for me is the hardest to do. But then it's like once you get going, you find, oh, it's actually it flows easier and so on, like anything. So it's as an additional component, I think it's again should be recommended to everyone.
Yeah, I agree.
And so, how do you diagnose it? What are the symptoms specific you're looking at, and how do you compare it, for example, to migraine, and then know what are some of the differences there between the two, or other types of headaches?
Yeah. So right now, there's no test for migraine or for cluster headache, either one. There's no blood test that says you're positive for cluster headache. There's no imaging test that says you're positive. We sometimes will get those things to rule out other problems, but right now it's made just like actually a psychiatric diagnosis. You come in, you explain your symptoms, and they say that sounds like cluster headache. And so there's just a list of criteria. If you check all the boxes, you have cluster headache. So it's the timing, 15 to minutes to 3 hours. It's the location. It's those features on the paint, on the face, the eye watering, the nose running, and those kind of restless features. So we just have this kind of checklist. You can look it up online to see the official definition, but we just make sure it's consistent with that. So one of the things that the headache docs basically have when they see you is they have that list of all these different types of headaches in their head, just saying that one's, pattern recognition. That one seems like a migraine. That one seems like a cluster headache. It's migraine is a little bit different. Migraine is when I teach my students, I like to tell them it's kind of what in a movie they depict as a hangover headache. It's throbbing, the light hurts, the noise, lights bother you, noises bother you, movement bothers you, you're nauseous. Now, patients with migraine will tell you it's not exactly like having a hangover, but for someone who's never had a migraine, I like to explain it that way. And one of the differences between migraine and cluster headache, migraines last 4 hours or longer, up to about 3 days. Cluster headaches are 3 hours or less. So if you just ask the patient how long do they last, you can already separate the two. The other is migraine patients tend to not want to move. They tend to lie still. If they move around during a headache, it makes it a lot worse. Cluster headache patients, on the other hand, they can't sit still. They're rocking, they're pacing around the room, they're walking outside, they just kind of fidget or are constantly in motion. And so if I ask a patient not only how long does it last, but what do you do during a headache? Do you try to lie still? Do you try to get up and move around? And usually it's pretty obvious if a migraine patient versus a cluster headache patient, what kind of answers you get.
And intensity is also different. You say cluster headaches are more intense generally in terms of
Cluster
pain.
headaches are more intense, although migraines can be pretty bad.
Mhm.
Now, I've had patients with cluster headache say I had to reinvent my 1 to 10 scale of pain once I had a cluster headache. So, and so migraine patients may not know that level of pain, but I think I would say that the cluster headache patients, that pain never gets less than a 7 out of 10. Like that's kind of where it starts and goes up from there. For migraine, it may start more like a 4 out of 10 and go up from there. So the max could be the same, kind of the minimum pain could be different.
Is it different parts of the brain? Because I think for my migraines, it was always one side that was hurting. Is that similar, or are there some differences there?
Yeah, so it's both of them are usually just on one side.
Okay.
Now, for cluster headache, they might be side locked. And what I mean by that is they're on one side your entire life. They never switch to the other side. A lot of migraine patients will tell you, I have them one-sided, but they'll switch sides. So if I have a headache on Monday, it'll be on the left. If I had a headache on Thursday, it'll be on the right. Some migraine patients also have them side locked
Mhm.
their whole life, but both of them are kind of usually around the eye and or behind the eye and just one-sided.
As a neurologist, do you see like maybe certain things in the brain that can go veins that are might be causing it? What do you think? What is your perception of that?
Yeah, I mean that's just a great natural thought. That was the original thoughts for both migraine and cluster headache, where it's either coming from the brain or it's coming from the arteries around the brain. So one of the interesting things about the brain is it does not have pain sensors in it. So you may have heard of these awake brain surgeries where they're moving electrodes through the head and patients aren't screaming in pain because the brain itself doesn't have sensors. So could it be instead of coming from the brain, is the brain activating some pain system, or is it actually coming from outside the brain? It's an artery around the brain because those are pain sensitive. It's the lining called the meninges that kind of is a covering the brain, and that's very pain sensitive. For cluster headache, originally it was thought to be a blood vessel issue, but now it seems to be a particular part of the brain called the hypothalamus. And we know that because those triggers that you had asked about earlier, nitroglycerin, some very brave patients took nitroglycerin, and then they put them in an MRI scanner and saw which parts of your brain light up when the headache first starts. And so they saw that this hypothalamus area kind of activated first. It's the same area for migraine. There's a couple other areas that also may activate at the beginning of a migraine, but the hypothalamus is one of them. Same thing, some very brave migraine patients went in, took some sort of trigger, went into the MRI scanner, and those are the kind of things we saw. So we think it probably starts in the brain, and then activates either other areas. So it could theoretically activate the lining around the brain. We think that might happen in migraine, or it's just activating the pain areas and makes it feel like you have pain in the lining around the brain.
Now, you say you don't see a cure. Do you think it is possible, though, to find one? As with the research, is this a possibility that we might find something that would cure it, or again, certain other things that might work to help us cure it or get rid of it?
Yeah, that's obviously the hope. And if I can kind of change the word cure a little bit, it may be hard right now to say that there's something you can do to never have them again and never have to take any treatment again for the rest of your life. But the, going back to earlier, this idea that it gets turned on and off, theoretically, there might be something you could do to keep it off permanently. Um, Now, I don't know if that's taking a medicine every so often to kind of shut it down again in case it's restarting. I don't know if there's a device that could be implanted in, around your head or in your nerve somewhere that could keep it off. But theoretically, something's getting turned on and off, and we could figure out what that switch is and figure out something to keep that switch in the, correct position. That would be my thought of, that's where we're closest to finding a cure.
And are there other treatments that you're experimenting with, like something like deep brain stimulation, or again, as you're saying, like maybe different other ways of trying to find out what could give a longer relief from it?
Yeah, so there's a huge list of treatments for cluster headache, both as needed and preventive.
Mhm.
And the odd thing is they don't have a lot of commonality between them. So what I mean by that is, for example, two of the best treatments to break a headache are sumatriptan, which is a migraine medication, and oxygen gas, like literally just the gas on your face. You have to have a pretty high dose of it, but it helps. Those two things have very little in common with each other. So it kind of helps, helps us know how to treat them, but it doesn't help us figure out new drugs. Um, Same thing on the preventive. There's a blood pressure medicine that works really well. There's a bipolar medication. There's a new migraine medicine that works very well. And you put them all together and you can't really see a common direction to find new drugs. So that's been a major limitation, is that we can't just go to the last drug and make a drug like it that works better. They have done stimulators, including deep brain stimulation. People have put one in the hypothalamus to see if it helps. The data is controversial on that one. What I mean by controversial is there are publications that it works really well. There's guidelines that say after we reviewed all of the data, we're not so sure it works that well. And it's a pretty invasive surgery, so we're not sure we would want to recommend something that may not work as well as we think it does. There have been other devices that have been proposed. There was one that I think the company went out of business or into receivership or whatever the right term is, but it was implanted under your cheek in a nerve bundle.
Wow.
And you put this kind of basically a wireless charger right over to activate it. So it's kind of like having an iPad in your cheek and then the wireless charger on top of it to activate it, to kind of charge it. So it was small enough without a battery. Nowadays we put a device in the back of your skull, an occipital nerve stimulator. So it's outside your skull over the occipital nerve, and it constantly kind of activates that nerve, kind of jumbles the circuit for pain, if you will, kind of confuses the signal that's trying to signal pain. None of these are perfect, but they do work for patients when nothing else does. They're usually not our go-to first-line treatment because they're more invasive than taking a pill, but we do have some different things there, and those are probably things that, if we could ever find that switch that turns it on or off, we could put one of these stimulators near it. In the past, neurosurgeon would go in and try to cut that area of the brain out. but that's obviously very, has a lot of damage or has a lot of side effects. And so these stimulators are great because you can kind of change the settings, and if something happens, you just turn it off and take it back out.
Yeah, exactly, exactly. There's a way out of it if it doesn't
Right.
work. So as how did you get interested in studying headaches and so on as a neurologist? Is that something that it personally resonates with you? You've had experiences, or why did you choose this field of study personally?
Yeah, I don't have a personal experience with it. I don't have a family member, or I don't have headaches particularly bad myself.
Mhm.
Um, I got into it just because I really liked these patients. I liked the patient population. And so in neurology, there's multiple different areas you can specialize in. You can specialize in epilepsy or Parkinson's and similar disorders, or a stroke, but there's a lot of different areas. Headache and pain are two different areas. And while I was going through my residency, doing all the different areas of training, this group of people just really resonated with me for whatever reason. I was fascinated by it. Patients were very grateful because you're helping their pain. You're talking about the thing they want to talk about, right? Yes, I want to talk about what my MRI shows, but I want to tell you what my day-to-day is like, and I want you to fix that. And that's what you're doing with headache. And so I just really enjoyed this group. And then cluster headache to me is just a fascinating research area. I'm a MD PhD myself, so I did an MD and a PhD, kind of a combined training. And so I have a little extra research training. And so I'm always looking for just really fascinating research questions. And this weird timing to the headaches, this kind of shutting on and shutting off, the fact that it's not researched that well, all of that was just very fascinating to me as a kind of an area to research.
Yeah, it's very noble and beautiful. I mean, to take away pain, people are suffering, and you're helping them. And we especially when it comes to headaches, which is very troubling. I mean, the only thing similar to that is may be a toothache, where it's like your dentist becomes the person who can help you with that. But when you get things like other things like maybe diabetes or blood pressure, where it's not as clear because you don't like necessarily suffer the pain. So I think that's wonderful work that you're doing, and I think that's your patients truly appreciate that when you're helping them.
Yeah, thanks. It's fascinating. The first time I'll see patients, and I'm sure a lot of other headache and pain doctors are like this, I'll sat through, kind of gone through all their history. I'll say, okay, here's the plan that I recommend. Do you agree with this? And at the end, they'll say thank you. And you know, it's it it's amazing because I always say, well, I haven't done anything yet. We just sat here, we just talked. The treatments haven't worked yet. You haven't even picked them up from the pharmacy or tried them out yet. And it's just grateful patients, and it's a nice kind of environment to be in. And I don't mean they're saying thank you like because I've done something great, because I haven't. All I've done there is kind of talk to them so far. But it's a very nice environment. It's something I really enjoy doing, and then obviously when patients come back and they feel better, you feel good about that. Some patients don't, and that's the challenge. But I kind of think of that as, that's a challenge that we face together. You're not better and you're not happy about it. I'm also not happy about it. So let's sit down and figure out, what else we can do to tackle this.
Wonderful. Thank you so much, Dr. Mark Burish. Such a pleasure talking to you. Thank you for sharing your knowledge, your research, and thank you so much for being on Arash's World.
Thank you very much for your time. Appreciate it.